Now we'll talk about the treatment of sepsis, and it's considered as a medical emergency, and the most important change in the revision of the Surviving Sepsis Campaign bundles is that the 3-hour and 6-hour bundles have been combined into a single 1-hour bundle with the explicit intention of beginning resuscitation and management immediately. The first step is measuring the lactate level. If it was more than 2, we should repeat it within 2 to 4 hours to guide our resuscitation. Then we obtain blood cultures before antibiotic administration, because sterilization of cultures can occur within minutes of the first dose of appropriate antimicrobial. So cultures must be obtained before antibiotic administration to optimize the identification of pathogens and improve the outcomes. And appropriate blood cultures include at least 2 sets, aerobic and anaerobic. But the administration of appropriate antibiotic therapy should not be delayed in order to obtain blood cultures. Then we administer broad-spectrum antibiotics. The early effective fluid resuscitation is crucial for the stabilization of sepsis-induced tissue hypoperfusion or septic shock. Given the urgent nature of this medical emergency, initial fluid resuscitation should begin immediately upon recognizing a patient with sepsis and hypotension or elevated lactate levels more than 4 millimole per liter, and completed within 3 hours of recognition. The guidelines recommend this should comprise a minimum of 30 ml per kg of IV crystalloid fluid, which is approximately 2 liters in 70 kg patients. Urgent restoration of an adequate perfusion pressure to the vital organs is a key part of resuscitation, so we apply vasopressors if the patient is hypotensive during or after resuscitation to maintain a mean arterial pressure of more than 65 millimeter mercury. The timely administration of antibiotics together with the appropriate control of the source of infection is crucial to limit sepsis and prevent organ injury. The recommended approach is based on the administration of empiric broad-spectrum antibiotic therapy as soon as sepsis is diagnosed, then to be switched once identification and sensitivities have been obtained. Empiric antimicrobial therapy should be narrowed once pathogen identification and sensitivities are established, or discontinued if a decision is made that the patient does not have infection. The balance between the advantages and potential damages of broad-spectrum antibiotics should be regularly evaluated, as these may entail the overgrowth of potentially pathogenic bowel flora and increasing bacterial resistance. A 12% reduction in survival was associated with each hour of delay in the administration of antibiotics following the onset of septic shock. In the first 12 hours following diagnosis, a specific anatomical diagnosis of the infection should be carried out as rapidly as possible, and intervention undertaken to establish source control. For example, infected peripancreatic necrosis and infected intravascular devices. The focus here is on mean arterial pressure, central venous autosaturation, and lactate level. The maintenance of adequate arterial pressure is a key factor for organ, and the mean arterial pressure target is hence used as an indicator of tissue perfusion pressure. Visualized therapy based on pre-existing hypertension and responses to therapy seems the most appropriate approach, but mean arterial pressure of 65 mm mercury or more is currently recommended. Increased lactate levels are associated with poor outcomes, and rapid lactate decreases are associated with higher survival. Fluids are the principal drugs for hemodynamic resuscitation in septic patients. However, there is increased awareness that these must be used with the same caution as any other IV drug in terms of both amount and type. There is no clear evidence to support the use of colloids over crystalloids in sepsis, and there is convincing evidence that the colloids containing hydroxyethyl starches are associated with a higher incidence of acute kidney injury and mortality, and there is evidence that normal saline or 0.9 sodium chloride causes hyperchloremic acidosis, particularly when administered in higher doses. This may result in acute kidney injury and increased mortality in critically ill patients compared to balanced crystalloid solutions. Norepinephrine is the recommended first-line vasopressor, with epinephrine or low-dose vasopressin as a second-line agent. Now, as the use of vasopressors is associated with untoward side effects, including organ dysfunction and atrial fibrillation, It's also important that the administration of such drugs be limited. Now, to establish the hemodynamic stability, IV hydrocortisone is recommended in conditions where fluid resuscitation and vasopressor therapy are insufficient. A strategy of increasing the delivery of O2 with red blood cell transfusions as part of hemodynamic goal-directed therapy did not influence the survival, and a recent study found no difference in 90-day mortality or the rate of ischemic events in patients with septic shock to a transfusion threshold of 7 or 9 gram per deciliter hemoglobin. Other therapies like immunostimulation and extracorporeal therapies needs further research. Thank you.